Welcome to the deep dive.
Okay, today we're going to really focus in on Whipple's disease. If you're revising for the MSRA, this is definitely one you'll want to have a good handle on. It's rare, sure, but understanding it really helps.
Absolutely. It's a classic example, really, of a systemic infection from one specific bug.
We've got our revision notes here, and the plan is simple. Pull out the absolute core stuff you need to know about Whipple's. From what it is, right through to how it can go wrong, make it stick.
Sounds good. Let's do it.
Okay, so starting right at the beginning, definition. What exactly is Whipple's disease?
Right. So fundamentally, it's a rare systemic infectious disease. The culprit is a bacterium called Tropheryma whipplei.
Tropheryma whipplei. Got it.
And while we often think of it affecting the small intestine first, and it does,
Right.
the key thing is that it can and often does affect many other parts of the body. It's systemic.
Systemic, okay.
Mhm.
And our notes mentioned some key characteristics, things like weight loss. Yeah, definitely. Weight loss is a big one. Often a chronic cough, too, which can seem a bit random. And problems absorbing fat, so fat malabsorption.
And lymph node involvement, too.
Yes, lymphadenopathy is common. And it's interesting, the actual bacterium, Tropheryma whipplei, wasn't even identified until 1992.
Really? That recent? Wow.
Yeah, and
Yeah.
we think it's probably acquired enterically, so likely ingested somehow.
Okay. And are there specific groups who seem more prone to getting it?
Well, the notes point to a couple of things. It seems to be more common in people who are HLA-B27 positive.
Ah, the HLA Association.
Exactly. And also, typically, it affects middle-aged men more often.
Middle-aged men, HLA-B27. Okay, that helps paint a picture.
So that leads us to the cause, the etiology. It's simply this bacteria.
Pretty much, yes. The direct cause is getting infected with Tropheryma whipplei, most likely, as we said, through ingestion.
Right. But why do some people get it? Are the risk factors clear beyond the HLA link and the demographic? Well, they're not super well defined, to be honest. Research is ongoing. But there's definitely a suggestion that genetic factors play a role. Maybe some kind of immune system dysfunction makes certain people more susceptible.
Which fits with the HLA link.
Exactly. And we see it more in white populations. Plus, there have been family clusters reported, which again points towards some sort of immunogenic component.
Interesting. Any geographical patterns?
It does seem to be more prevalent, or at least more reported, in Western Europe and North America.
Okay. And I remember seeing something about occupations.
Yeah, there's a slight suggestion maybe of higher risk for people like sewage plant workers, farmers, agricultural workers. It hints at potentially an environmental source or exposure route, but it's not concrete.
Plausible. And any other specific genetic markers mentioned besides B27?
Yes, the notes also list HLA, GRB113, and DQB106 alleles as possibilities that researchers are looking into for susceptibility.
Okay, so it seems like it's probably a mix. You encounter the bacteria, and maybe you have a certain genetic or immune background that makes you more likely to develop the disease.
That seems to be the current thinking, yeah.
So let's talk pathophysiology. What actually happens inside the body once someone's infected? Step by step.
Okay. So the bacteria, Tropheryma whipplei, it invades the lining of the small intestine, the mucosa.
Right.
This invasion triggers inflammation. And what's kind of central to the disease is that this inflammation damages the cells responsible for absorbing nutrients in the intestine.
Ah, the absorptive cells. So that's the direct cause of the malabsorption symptoms we mentioned earlier, like the fatty stools.
Precisely. If those cells are damaged, your body just can't absorb nutrients properly, especially fats. And because it's a systemic infection, this initial problem in the gut doesn't stay localized. It kind of sets off a cascade leading to symptoms in other organs and systems.
Okay, so gut invasion, inflammation, cell damage, poor absorption, and then systemic spread. Makes sense. Now, given this wide range of symptoms, gut problems, cough, joint pain, weight loss, there must be quite a few other conditions that could look similar, right? What are the differential diagnoses we need to consider?
Absolutely. It's broad. For revision, it helps to group them. So first, think about other things causing malabsorption.
Okay, like what?
Well, coeliac disease is a big one.
Yeah.
Tropical sprue, maybe intestinal lymphoma, or even autoimmune enteropathy.
Right, other things messing with gut absorption. And what about conditions that mimic the systemic features, like the joint pain or fever?
Yeah, that's the other category. You'd have to think about things like AIDS, especially with Mycobacterium avium complex infection. Also inflammatory conditions like sarcoidosis, reactive arthritis,
Yep.
familial Mediterranean fever, Behçet's disease, IBD, inflammatory bowel disease itself, and even TB, tuberculosis.
Wow, that's a pretty extensive list. It really shows why it can be tricky to diagnose, especially given how rare it is.
Exactly.
Speaking of rare, let's zoom in on the UK. How often do we actually see Whipple's disease here?
It is extremely rare in the UK. The notes really hammer this home.
Okay.
And the demographic is pretty much what we see globally, mostly middle-aged white men.
Any actual numbers? Incidence or prevalence estimates?
Yeah, the global incidence is estimated something like 1 to 6 case per million people per year. So tiny. And the prevalence is maybe around 1.1 per million.
Really, really low numbers then. So if you do encounter a potential case, what are the key clinical features you'd be looking for? What are the main things that should ring alarm bells?
Well, the presentation is notoriously varied, which is part of the challenge. But some symptoms are definitely more common. Weight loss is very frequent, often with anorexia, loss of appetite.
Okay.
Diarrhea is common too. Abdominal pain, joint pain, arthralgia. You might see a low-grade fever that comes and goes. And neurological symptoms can pop up.
What about things like gas or fatty stools?
Yes, flatulence and steatorrhea, that's the fatty stools from malabsorption, are definitely on the list. Even GI bleeding can happen. And that chronic cough we mentioned earlier that's also reported.
It's quite a mix. Are there any specific signs you might see on examination?
Sometimes, yeah. Skin hyperpigmentation, darkening of the skin can occur. And lymphadenopathy, swollen lymph nodes. The real takeaway is just how many systems can be involved. Joints, gut, fever, cough, CNS, heart, eyes, skin. It can hit almost anywhere.
You mentioned neurological symptoms. Are those common? What kind of things are we talking about?
They're not the most common feature, but they are important because they can be serious. Things like headache, ophthalmoplegia, problems with eye movements, dementia, seizures, ataxia, which affects coordination, and myoclonus, those sudden muscle jerks.
That's quite a worrying list. Really drives home the systemic point. Now, for revision, trying to remember all that, is there a mnemonic that might help?
Yes. The notes suggest thinking of a WIPPID individual. So, W for weight loss, H for hyperpigmentation, I for intestinal issues, P for polyarthralgia, another P for peripheral lymphadenopathy, and N for neurological signs.
WHIPPN. Okay, WHIPPN. Weight loss, hyperpigmentation, intestinal polyarthralgia, peripheral lymphadenopathy, neurological. That's actually pretty useful.
Helps tie the main ones together.
Definitely. So let's say you suspect Whipple's based on this kind of picture. What investigations are key to confirming it?
Right, diagnosis. It really hinges on getting tissue samples. So endoscopy, looking into the gut with a camera and taking biopsies, is crucial, specifically from the jejunum or duodenum, the upper parts of the small intestine.
Okay, biopsies are key. What else?
PCR testing is very important now, looking for the bacterial DNA, Tropheryma, whipplei DNA, usually targeting the 16's RNA sequence. And then, of course, looking at those biopsy samples under the microscope, histopathology.
Are imaging tests like MRI useful?
They can be helpful to see the extent of organ involvement, say, if there's concern about brain involvement. But they aren't diagnostic for Whipple's on their own. You need the tissue or the PCR.
And what are you actually looking for in those biopsy results? What's the classic finding?
The absolute hallmark is finding macrophages, a type of immune cell, stuffed with granules that stain pink with a special stain called periodic acid shift, or PAS. So PAS-positive macrophages in the lamina propria of the small intestine.
PAS-positive macrophages. That's the money finding on histology.
Yeah, that's the one to remember, yes.
So it's really that combination, the clinical picture, the PAS-positive macrophages on biopsy, and maybe a positive PCR test.
Exactly. Routine bloods or general malabsorption tests won't pinpoint it. They'll likely be abnormal, but not specific. You need the biopsy and or the PCR.
Okay, diagnosis confirmed. How do we treat Whipple's disease, particularly thinking about UK practice?
Treatment is basically long-term antibiotics. It's essential.
Long-term, how long are we talking?
Typically 1 to 2 years. It's a serious commitment.
Wow. Okay. Which antibiotics?
Several can be used. Ceftriaxone is common, often given intravenously initially, especially if there's neurological involvement. Then follow-up is often with oral cotrimoxazole, maybe for a year or more. Doxycycline and hydroxychloroquine are other options mentioned.
So often starting with IV, then switching to oral for a very long time.
That's a common approach, yes. The exact regimen can vary, but the long duration is constant.
And is it just about taking the pills for 2 years? What about follow-up?
Oh, follow-up is absolutely critical. Regular checks are needed, and often repeat PCR testing is done, maybe even repeat biopsies sometimes, especially at the end of treatment, to make sure the infection is truly gone.
Right, checking for clearance. Is there a quick way to remember the treatment principle?
Maybe think Whipples with a long course of antibiotics, just to emphasize that extended duration. You can't cut it short.
With it good for a long time. Okay, so finally, prognosis and complications. If patients get this long treatment, how do they generally do?
The good news is, with the right treatment started promptly, the prognosis is generally good. Patients often feel better quite quickly symptomatically.
That's encouraging.
It is. But, and this is important, if it's not treated, it can be fatal because of all the potential organ damage. And even with treatment, while symptoms improve, getting full histological clearance, those PAS-positive macrophages disappearing can take longer.
And what about relapse? Is that common?
Unfortunately, yes. Relapse is a significant issue. The notes mention a relapse rate of around 40%, which is quite high.
40%? Wow.
Yeah. So even after completing that long course of antibiotics, patients need really close long-term follow-up to watch for any signs of disease coming back.
That relapse rate really underlines the need for that continued monitoring. Okay, so to quickly recap the key points for revision. Whipple's is rare, caused by Tropheryma whipplei, systemic effects starting in the gut. Think weight loss, cough, joint pain, gut issues. Neurosigns, remember, WHIPPM. Diagnosis needs biopsy showing PAS-positive macrophages, and PCR helps. Treatment is long-term antibiotics, often 1-2 years, like ceftriaxone, then cotrimoxazole, and crucial follow-up is needed due to that high relapse risk.
That covers the core information nicely, yeah. High index of suspicion needed in the right context.
Absolutely. And maybe a final thought for you as you're revising. Thinking about Whipple's really makes you appreciate how interconnected everything in the body is, how one little bacterium can cause such widespread havoc. It kind of makes you wonder about the longer-term effects of any chronic infection, doesn't it? Something to ponder.
Definitely food for thought.
And if you are looking for more resources for your MSRA revision journey, do check out pasthemsra.com and also freemsra.com. Thanks so much for joining us for this deep dive into Whipple's disease.